Hello and welcome to my presentation on Chapter 6's and 7's clinical correlates. So Chapter 6 is going to be talking about the 3rd to 8th week of embryologic development called the embryonic period. And then Chapter 7 is going to be about gut tube formation and the body cavities. So we are going to talk in this lecture about neural tube defects, which is the clinical correlate from Chapter 6, which include anencephaly and spina bifida. In Chapter 7, we're going to talk about ventral wall defects like ectopia cordis, exstrophy of the bladder, omphalocele and gastroschisis, as well as diaphragmatic hernias. And then we'll wrap it all up with how all of these different defects can impact the PA profession. So before we can talk about neural tube defects in anencephaly and spina bifida, we need to understand how the neural tube forms, which is going to be via the process of neurulation, which is the key process in which the neural plate becomes the neural tube. It's going to be regulated by the planar cell polarity pathway, and the key event in neurulation is going to be the lengthening of that neural plate or body axis by the process called convergent extension, which is a lateral to medial movement of cells in the ectodermal and mesodermal planes. So that neural plate is going to elongate and the lateral edges will elevate to form neural folds. Between those neural folds is going to be that depressed midline or neural groove. And those two neural folds are going to start fusing. The fusion normally happens around day 23 at the level of the 5th somite, which is in our cervical region. It's then going to extend both cranially and caudally. And since it's starting higher up, like more towards the head, it's going to finish on the cranial side much quicker than it finishes the caudal. And when it's all done, so it begins fusing around day 22, and by day 23, the fusion is complete, but the neuropores remain open. The neuropores are going to be the openings of between the neural tube and the amniotic cavity at the cranial and the caudal end. And these are going to be called your anterior and posterior neuropores, anterior being in the head region and posterior being in the caudal region. And these are going to close between day 25 and 28. So any defects are going to result due to the incomplete closure of those neuropores, or just any incomplete closure of the neural tube. These neural tube defects are the most common CNS malformation that you can see, and are going to result in midline malformations that involve some combination of neural tissue, meninges, and overlying bone or soft tissue. And depending on the degree at which they involve those neural tissue, meninges, and overlying bone / soft tissue, it's going to affect the severity of the pathologic process. So there are two pathologic mechanisms in which neural tube defects can happen. So there's essentially two ways in which this incomplete closure can cause injury. So you can have that failure of tube closure secondary to a mesenchymal tissue defect, which is going to stem from aberrant skeletal remodeling around a malformed tube. And that's how anencephaly is going to form. The other mechanism you can have is a primary bony defect caused by abnormal axial mesoderm development, leading to a secondary CNS abnormality, like you have a spina bifida. So it depends on if it stems from the mesenchymal tissue or if it stems from the bony tissue. So the occurrence of neural tube defects varies by region, and that's because folic acid is the #1 way to prevent neural tube defects. And depending on the region you're in, you may have access to enriched flour, which contains folic acid, or you might not. You may have no access to those key nutrients that would prevent all these defects. As of right now, we have not really identified any genetic causes, but there is the VAN-GL gene, which is identified as having something to do with it. And that's because it's involved in the polarity pathway, that planar cell polarity pathway, as well as the lengthening process of the neural plate. So we know it plays a role. Another key thing they use to test for to test for neural tube defects and to make sure embryonic development is going as planned is they'll test for alpha fetal protein, because if one of these defects is to occur, you'll see elevated levels of alpha fetal protein in both the mother's serum as well as in the amniotic fluid. Folic acid, when they recommend, and they will put this in all multivitamins for females, is 100 nanograms daily. And if you have a family history or personal history with having children who have these defects, they will actually recommend that you take 4,000 nanograms daily upon 3 months of trying to get pregnant, and then throughout the pregnancy. So the first neural tube defect we're going to talk about is anencephaly. So anencephaly is the malformation at the anterior or cranial end of the neural tube that leads to the absence of most of the brain and calvarium. So this can vary in severity. So you can have the entire forebrain not developing, you can have the entire brain not developing, and it's going to be, if we remember that the neural tube is going to, or the anterior neural pore is going to close at approximately day 28. And if you have that forebrain development being disrupted at the same time, it's going to lead to the lack of development of those neural structures. Any neural structures that do remain are referred to as the areas cerebrovasculosa. Anencephaly is lethal, and it can most of the time be diagnosed prenatally, and the pregnancy will be terminated. And a useful, fun little side note, this is one of the few forms of abortion that actually has been sanctioned by the Catholic Church under John Paul II. So grossly, you can identify anencephaly at the bench or in the forensic setting by the shrunken calvarium or absent calvarium. Spina bifida, on the other hand, is going to be the incomplete closure of the neural tube anywhere from the cervical region to the posterior neural pore. They're most commonly going to be found in the lumbosacral region, as you can see with that the bottom picture as well as the picture in the upper right. But it is important to note that it can happen anywhere in the thoracic, lumbar, or sacral region. The level at which the lesion occurs and its severity determine the degree of neurological function loss. So the level at which it occurs is going to tell you kind of, depending on the dermatomes that are involved or the skeletal innervation that comes off at that level and below, there might be neurological defects there. And then the severity of spina bifida is those three different categories underneath. So spina bifida occulta, spina bifida cystica, and myelomeningeal. So spina bifida cystica, or occulta, we'll start with occulta, is going to be occulta is an asymptomatic bony defect. So you're going to have a defect in one or more vertebral arches with no spinal cord involvement. Spina bifida cystica is going to be when you see cystic swellings of the dura and arachnoid protruding through that defect in the vertebral arches, but the spinal cord will stay in place. So it's not going to be associated with really bad neurologic problems. But your myelomeningeal are going to be severe malformations that will have flattened and disorganized segment of the spinal cords associated with overlying meningeal outpouching. So you're still going to get that cystic outpouching of the arachnoid and dura, but it's also going to be associated with spinal cord involvement. And myelomeningeal are going to have loss of neurologic function below the defect. So those are the big ones you want to look out for. These are almost all treatable. Myelomeningeal are not quite as treatable because they still do lose that neurologic function, just even if we can get to it. But occulta and cystic are extremely treatable. These are the most common of the neural tube defects. They're much more common than anencephaly. And some risk factors for whether or not a mother will develop these can include that folate, so whether or not she was given the recommended 400 nanograms. Diabetes mellitus will predispose. obesity, excessive heat during medication or during pregnancy. So that's why they recommend you don't spend a lot of time in a sauna if you're pregnant. There's certain medications, as well as if you have a family or personal history with neural tube defects. So next we're going to move on to ventral wall defects that can occur. So ventral wall defects are going to be any failure of the midline to fuse, form, etc. So these can occur in the thorax, abdomen, or pelvis, anywhere on the ventral wall, the ventral midline. And if they involve the heart, it's going to be ectopia cordis. If they involve the abdominal viscera, you'll see gastroschisis and omphalocele. And if they involve the urogenital organs, you'll have either a bladder or cloacal exstrophy. So these can be due to multiple things. So they can be due to a defect in the fusion of the lateral folds, or a failure of the right and left lateral folds to migrate ventrally. So first, they could just not stick together. They don't want to fuse, or it could be that they'd fuse just fine. It's just one or both don't make it all the way, so they don't even get the chance. It's going to more commonly affect the lateral folds than the head and the tail folds. So that's just letting you know that it's going to be more common on the ventral wall. So, quick overview. The ventral wall of the developing fetus fuses during the beginning of the 4th week, and that's when the lateral plate mesoderm fuses and separates into the visceral and parietal layer, and is going to then start lining your body cavities. It's going to create those body cavities, which are going to then further subdivide into the thoracic cavity and the abdominal cavity upon the diaphragm forming, which we'll cover later. So ectopia cordis, which is the first ventral wall defect we're going to talk about, is when the lateral body wall fails to close at the midline in the thoracic region, which can cause the heart to lie outside of the body cavity. If the defect spans the sternum into the upper abdominal region, it's referred to as the Cantrell pentology, which is going to include ectopia cordis, anterior diaphragm defects, the absence of a pericardium, sternal defects, and omphalocele and gastroschisis all associated with it. It is a pretty rare disease and pathology affecting 8 in every 1 million births. And so next we're going to talk about bladder or cloacal exstrophy. So this is what happens when you have the failure of the fusion of your lateral folds in the pelvic region or lower abdominal region. And what's going to end up happening is the urogenital, to some degree, is going to be exposed to the outside. Bladder exstrophy is a less severe malformation than cloacal, and that's just due to the amount of defect that the size of the defect that would have to occur for the rectum and the anus to also, or cloaca, to also be outside of the pelvis. So it's a much bigger hole than it would be for just the bladder. In males, if you have bladder exstrophy, it's going to be associated with another defect called epispadias, which is when you have the opening of the urethra on the dorsal side of the penis. The exposed bladder mucosa may undergo colonic glandular metaplasia, which does predispose it to and increase its risk for developing adenocarcinoma of the bladder. And because you have the urogenital tract or the bladder exposed to the outside environment, you are at a very high risk of developing chronic infections that can spread to the upper urinary tract and cause hydronephrosis or chronic obstructions and all of the consequences of having chronic UTIs. Next is going to be omphalocele. So these are omphalocele and gastroschisis, which is the next slide, are going to be defects of the ventral body wall in the abdominal region. So the difference between them is going to be the presence or absence of a membrane covering the herniation that happens. So omphalocele, you're going to have that amnion or a membrane, it can be skin, covering the herniated intestinal loops. Omphaloceles mainly are going to occur when the extraembryonic gut fails to return to the abdominal cavity after it undergoes a physiologic umbilical herniation. And thus, when the body goes to close, it's trying to close around its own intestines, and therefore the musculature cannot close and fuse. So abdominal musculature is incomplete. So the ventral body wall defect is secondary to the gut's failure to return. So this one is kind of a break into those two mechanisms that we talked about, where either they couldn't, or this would be that second one, sorry, where it just couldn't migrate because there was something in the way. So the hernia will be covered by amnion and peritoneum, and as well as a Wharton's jelly because it's herniating into the umbilical cord. So it's important to note, because this is a differentiating factor between omphaloceles and gastroschisis, that the hernia in omphaloceles can also contain the liver as well as the midgut. It's a fairly common birth defect of 2.5 in 10,000 births, and it has a high mortality rate due to associations that it has with cardiac abnormalities as well as neural tube defects. 15% of omphaloceles are going to be associated with chromosomal abnormalities. And it's also going to be associated with high alpha fetal protein concentrations in the maternal serum as well as the amniotic fluid. This particular defect is going to occur during the 6th to 10th week of gestation, which is when the physiologic umbilical herniation is normally happening. Gastroschisis, on the other hand, is going to occur when the midgut herniates through all of the layers of the abdominal wall. So it's not herniating into the umbilical cord, it's herniating through the entire abdominal wall, normally to the right of the umbilicus. And this is going to be limited to the intestine. So with the omphalocele, we had the liver also being able to herniate, versus gastroschisis, you're only going to have the midgut or the intestine. It's an isolated defect. So unlike omphalocele, which we saw was associated with other neural tube defects and cardiac abnormalities, gastroschisis is going to be isolated and only associated with other defects about 15% of the time. The rate of gastroschisis is increasing. And this one is also going to be associated with high alpha fetal protein concentrations in that maternal serum and fetal amniotic fluid. But most commonly, it is associated with women who get pregnant when they're extremely young and thin, as well as white women are predisposed. This one, unlike omphalocele, has no chromosomal abnormalities associated with it, while omphalocele did. And of those 15, this is just a kind of side note I found interesting, of those 15% defects associated with gastroschisis, 5% are going to be heart defects. And then it's important to note, especially for our practice, when we see gastroschisis, that it's important to assess the mucosa of the exposed bladder walls, or of the exposed intestinal and midgut walls, because amniotic fluid is very corrosive on exposed mucosa, and it can damage the mucosa and the outer linings of said organs. So gotta watch out. So these are two photos. The one on the left is going to be an omphalocele, which you can identify by the fact that one, it's going into the umbilical cord, and two, it has that amniotic, the amnion covering as well as the peritoneal covering. And the dark color you can't use it to identify if the liver is present within that herniation, but the liver could be present within them. Versus the one on the right is gastroschisis, and you can tell because one, it's not going through the umbilical cord, and two, it is not contained within a pleural sac or within an amniotic sac or by a membrane of any kind. So next we're going to talk about the overview of the diaphragm. So now going over diaphragm formation and how the body cavities kind of get separated into that thoracic and abdominal region. So I always think of this easy if you imagine a disc. On the anterior portion, you have the septum transversum. And then adhering to each posterior lateral wall, you have the pleuroperitoneal folds. So over the course, and then in between, those don't extend all the way to the septum transversum, there's going to be the pericardioperitoneal canals. Over time, those pleuroperitoneal folds are going to extend and kind of start obliterating those pericardioperitoneal canals and migrate towards that anterior septum transversum. And as they do that, they're going to start thinning. And about the 7th week, they're going to be thin enough that they get a name change and they become the pleuroperitoneal membranes, in which they will adhere themselves to the esophagus on the midline, get dragged down partially to form the crus or crura of the diaphragm. So this membrane is then going to be penetrated by migrating myoblasts to add that muscular layer. And that central tendon is going to be where those membranes, the pleuroperitoneal membranes, fused. And that's going to be why it does not have any muscle there. So the diaphragm, once it is fused, is going to create the embryonic body cavity, or it's not going to create, it's going to be what divides the embryonic body cavity and subdivide it into that thoracic and abdominal cavity. So that thinning of the mesentery that I talk about on the 3rd bullet point, that is going to be how these particular defects happen. So in a normal development, the mesentery that holds the foregut to the posterior body wall, that thins and becomes a mesentery, or becomes the dorsal mesentery, which allows for the esophagus to elongate and stretch. And if it does not happen correctly, so let's say that mesentery never forms and the esophagus stays strictly adhered, the stomach is going to herniate through the diaphragm, which is going to be what we're going to, diaphragmatic hernias, which we're talking about. So there's 2 different mechanisms in which this can occur. So muscle cells don't populate the peritoneal membrane, like I said, pleuroperitoneal membrane, which is going to cause it to be extremely weak. And then it's going to allow for the stomach to and abdominal organs to kind of push their way up. And the second way is the dorsal mesentery fails to form, which leaves the foregut a little too short. And that's going to cause the stomach to essentially form halfway in the thoracic cavity and halfway in the abdominal. So these hernias, they vary in severity due to the fact that it depends on how long did the developing foregut get to. Is the stomach completely into the thoracic cavity? Is it only partially? So it depends on the extent of the hernia and the organs that are involved. So if you had one that the stomach is up there and due to myoblasts not proliferating correctly, the left side is completely open, as seen with picture B, you can get the colon, you can get the intestines, you can get the stomach all up into the thoracic cavity, which is going to cause pulmonary hypoplasia because it just can't expand. You're taking away, same way when you have a extremely large heart, it's going to decrease your lung capacity. If you had abdominal organs into the thoracic cavity, it's going to also decrease lung capacity and cause pulmonary hypoplasia, which is normally fatal. So 85 to 90% of our congenital diaphragmatic hernias are going to occur on the left side of the diaphragm. And it's going to be due to that first mechanism we talked about, which is the failure of the muscle cells to populate that section. You can have it happen on the anterior or peristernal wall. And these are actually going to result in tiny little hernias that almost always go undetected until death, unless they develop necrotic tissue and can cause you to go septic. So that's kind of it for congenital diaphragmatic hernias. So lastly, we're going to talk about kind of how all of these different defects impact us as PAs. And the main thing is they are important to recognize both at the bench and in the forensic setting. Because with all of these, especially with like neural tube defects, the family should be notified or the mother of the child with the defect needs to be notified, because it's going to impact whether or not they get a increased dosage of folate acid if they want to get pregnant again. It's going to impact how they have to go through with the process of getting pregnant. You need to be able to recognize it so proper treatment can be taken. So that's going to be with our spina bifidas, which are very not easy to fix with surgical correction, but they're possible to fix with surgical correction. But if you, let's say, did not notice that it was a cystic outpouching and you just said it was spina bifida occulta instead of cystica, you weren't going to take the same treatment, and it's going to affect that child. So any errors in diagnosis, once again, that's going to be spina bifida occulta, or if someone mistakenly diagnosed gastroschisis as omphalocele and they took a bowel resection, which got to your bench, and you noticed that there was an amnion or a membrane surrounding the portion of the midgut that you got. You can catch, if you know the difference, you can look at the medical history and realize that there was an error made by someone. Finding associated pathologies. So neural tube defects are going to be associated with teratomas in 10% of the cases. And if you know that you're at the bench, or you have a POC or an embryo, or you're doing a fetal autopsy where you have a neural tube defect like spina bifida or anencephaly, you're going to know to look for maybe they had a teratoma somewhere that was impinging or causing other defects within their body. You need to be able to recognize, because with a lot of these, especially our neural tube defects, we don't know if there's a genetic cause. And we might want to send them out for cytogenetic testing or for research, because there's still a lot of active research being done on these, as they kill children, which is normally a pretty big, will pull a lot of attention. So it's just very important to recognize a lot of these pathologies, as they can impact all sorts of different areas in the medical field. So then we have our questions. So first one is true or false. Diaphragmatic hernias on the left side of the diaphragm are almost always caused by the failure of muscle cells to migrate and populate the pleuroperitoneal membrane. Question 2, all of the following regarding gastroschisis are true except. 3, true or false. Diaphragmatic hernias in the peristernal region are normally fatal due to their close relationship with the heart. Spina bifida blank is associated with defects in one or more vertebral arches and cystic swellings of dura and arachnoid protruding through the defect. Question 5, which of the following statements regarding ventral wall defects is correct? And then here are my citations. Hope you enjoyed. Have a good one.